All right, I think we'll get started. I'm Kelly Loss. I'm the librarian of the Ethics Center. I'm here with Dr. Elizabeth Hilt, and we're extremely happy to welcome Dr. Michelle McGowan to present her webinar today, um, entitled Ethical and Logistical Considerations in Implementing Decentralized Genomic Research Trials. Dr. McGowan is a professor of biomedical ethics and co-director of the Biomedical Ethics Research Program at the Mayo Clinic in Rochester, Minnesota. She completed her BA in sociology at Boston College, a PhD in women's studies at the University of Washington, and a postdoctoral fellowship in bioethics at Case Western Reserve University. Prior to joining the Mayo Clinic in 2022, Dr. McGowan held the faculty positions at Case Western Reserve University, Pennsylvania State University, and the University of Cincinnati. Dr. McGowan is an empirical bioethicist whose research explores the ethical and social implications of emerging health technologies and policies. Combining a range of qualitative and normative methods, her empirically informed approach to bioethics scholarship focuses on addressing the uneven distribution of benefits and burdens associated with the uptake of technologies in healthcare and biomedical research. She is currently a principal investigator of a multiple PI National Human Genome Research Institute funded hybrid clinical trial focused on adolescent decision makings in relation to prospective genetic test screening. So please join me in welcoming Dr. McGowan. As I mentioned earlier, we're going to save questions to the end of the chat. And once we're there, you can either raise your hand and you can unmute yourself, or you can put your questions in the chat. So with that, Dr. McGowan, please go ahead and start.
Thank you so much for that lovely introduction and for the opportunity to share my work with you all today. As Kelly mentioned, I'll be talking with you about ethical and logistical considerations in implementing decentralized genomic research trials. I'll start by giving an overview of some of the ethical debates related to decentralizing clinical research, and then I'll shift to a case example from my own clinical trial in which we have a decentralized arm of what's called a hybrid clinical trial, where participants can either participate in person or fully remotely. So with that, I'll get started. So clinical trials and clinical trial activities are typically conducted within clinical settings, such as academic medical centers, research clinics, and clinical research organizations. Decentralized clinical trial design enables some or all clinical research activities to occur outside of these spaces, with the goals of benefiting participants and using technologies to lessen the burden of conducting clinical trials. Utilization of decentralized clinical trial design increased during the COVID-19 pandemic, in part due to restrictions that organizations put on utilization of clinical research spaces to limit the spread of COVID-19. Several factors contribute to the increasing appeal of decentralized clinical trial design, including faster and broader recruitment of eligible participants, particularly for people with rare diseases, those who are immunocompromised, or those who live far from clinical research centers. Design that may be less burdensome to participants than coming into clinical research settings is appealing in that regard, which is thought that it was thought that it would increase participant retention and reduce the costs of conducting clinical trials overall, which can be prohibitive for many organizations to endeavor. Proponents have argued that decentralized clinical trial design could address some of the barriers to participation in research that have contributed to the chronic underrepresentation of specific populations in clinical research. And what we'll focus on today is particularly with the participation of children in research, but it's been well documented that the racial demographic makeup of clinical trial participation is overly represented by people with European ancestry. Specifically, proponents have argued that bringing trials to participants rather than drawing participants to clinical trial sites may reduce travel and cost burdens of participation and increase the accessibility of research participation to a variety of populations that have been underrepresented in clinical research, thereby increasing the potential for clinical trial results to represent the patient populations they're meant to serve overall. So I'll walk through a variety of ethical considerations that have been detailed in the literature over the last several years. In 2023, the Food and Drug Administration released draft guidance on decentralized clinical trials. This guidance focused on familiar ethical considerations such as safety and veracity to promote participant welfare and scientific validity of clinical trials. Regarding safety, the guidance indicates that decentralized design is appropriate for investigational product trials that do not require participants to undergo complex medical assessments and recommends that decentralized trial protocols articulate how adverse events will be identified and managed for remote participants. The FDA guidance also recommends confirming participants' identities during each remote study visit to ensure veracity or accuracy of data generated through decentralized clinical trials. Beyond the Food and Drug Administration guidance, scholars have raised normative concerns about decentralized clinical trials regarding participant safety, veracity of data, informed consent, data protection and securities, burdens on study participants, and adequacy of ethical oversight. So I'll go through each of these in turn. Starting with participant safety, this has garnered significant debate, ranging from concerns about participants' handling of investigational products to inadequate interaction with decentralized clinical trial staff, potentially posing risks to participants. Some ethics committee members have suggested that lower risk trials may be more appropriate for a decentralized format than higher risk studies. However, other scholars have argued that continual monitoring techniques used in decentralized clinical trials may promote investigators' timely awareness of adverse events, thereby potentially increasing participant safety over traditional clinical trial design. Regarding veracity, scholars have argued that self-reported data, uneven research conditions, limited interaction with study staff, and unsupervised use of technology in decentralized trials may negatively impact the quality, reliability, and accuracy of research data. Scholars have raised some concerns about how investigators can ensure the veracity of participants' identities, particularly when there's limited face-to-face contact with the study team. These scholars have also questioned the adequacy of participant comprehension when providing remote consent to participate in decentralized trials. Informed consent processes used in decentralized trials vary considering the specific study in mind, and it may depend on whether the study is hybrid, with some study activities taking place in a traditional research setting or fully remote. Some decentralized clinical trials use asynchronous informed consent processes whereby research prospects review consent materials and sign consent documents remotely without a synchronous contact with a study team member. There's little empirical evidence to show whether face-to-face or asynchronous consent impacts participants' comprehension of study procedures, risks, and alternatives. Though hybrid decentralized clinical trials where informed consent discussions take place face-to-face or synchronously could promote rapport and trust building between participants and the study team, and thereby ensure the veracity of participants' identities. Data protection and security is of paramount concern with decentralized trials, particularly when third-party organizations and digital devices are involved in collecting, storing, or managing data generated in decentralized trials. Participant privacy during remote study visits cannot be managed by the study team in the same way that it could be in a traditional research environment, which may be viewed as an inherent limitation of the approach should participant privacy be highly valued, as it has been as an ethical imperative in a lot of other research. While decentralized clinical trials are touted for their potential to alleviate the burdens of participation, technical complexity or material failures associated with the use of digital technologies and self-administration of tests or investigational products may inadvertently burden study participants and thereby increase investigator costs. Ethicists have argued that the ease of digital communication could also increase burdens on study participants over traditional clinical trial design, and suggest that investigators limit digital interactions to the extent possible. Some ethicists have also raised concerns about the adequacy of ethical oversight for decentralized clinical trials. Specifically, research ethics and compliance bodies charged with reviewing decentralized clinical trial protocols may lack familiarity and expertise with research involving decentralized and digital tools, and may benefit from shared resources regarding unique ethical and regulatory aspects of the technologies involved. At this point, it's unclear whether a precautionary or observational approach would be more appropriate as decentralized clinical trials become more prevalent. but unevenness and overprotectionism may prevail as institutional review boards review protocols locally. Considering the justice implications of clinical trial design, increasing the population representativeness of clinical trials remains a high priority for investigators and research funders to address gaps in our understanding of diseases and conditions, preventive factors, and treatment effectiveness across populations, as has been forth by the National Institutes on Minority Health and Health Disparities. The proponents of decentralized clinical trials argue that moving clinical trials out of traditional research settings will increase the diversity in clinical trial participation. Inadequate attention has been paid to how investigators can use decentralized clinical trial design to increase researchers' rapport with communities that experience medical distrust and health disparities that have historically been underrepresented in clinical research. So, as my colleagues and I have published in the American Journal of Bioethics, there are a variety of logistical considerations that may hinder and could potentially impact the ability of research teams to translate their trial designs into decentralized formats, which could both result in underprotection and overprotection of research participants, depending on the particular barrier. For instance, institutional barriers may come from institutional review boards, marketing and communications, general counsel, all entities that may interface with research, but that could promote or hinder efforts to decentralize clinical trial activities. Material costs related to trial design and implementation, such as participant-led sample collection, may result in additional costs to research teams, depending on user error, loss of samples, et cetera. Environmental challenges and personnel time as well are things that researchers and their teams need to consider when transitioning to decentralized design. Personnel time and energy managing engagement with participants via tech support is, for instance, quite different than one might expect when conducting study visits in a setting where you don't expect to have those types of interaction difficulties. Privacy and data protection may be more difficult for investigators to ensure, particularly if participants are conducting trial activities in distracting environments without privacy. Findings from some decentralized studies have been relatively demographically homogeneous, often white, highly educated, and higher income research participants. And see, for example, some research that has been conducted by the 23andMe research team, which suggests that simply shifting to a remote study format or decentralized study format may not necessarily lower barriers to participation for some communities or populations that have been less likely to participate in clinical research. Furthermore, decentralized clinical trial design may inadvertently result in selection bias due to inadequate digital literacy or access to technology and the internet, otherwise known as the digital divide, potentially limiting the capabilities of certain populations, such as people living in rural areas, older individuals, people with disabilities, and people experiencing financial disadvantage from participating in decentralized studies. So the digital divide could thereby exacerbate rather than ameliorate inequitable participation of some populations in clinical trials. Nevertheless, bioethicists and legal scholars have argued that remote health research may afford participants more control over the research experience, which has potential to disrupt power dynamics that have historically existed in clinical research. The accumulation of empirical evidence on decentralized clinical trial should illustrate whether and how this materializes. So to give you a case example, I'll turn to my own clinical trial, which is a pediatric prospective genomic screening study. For those of you who are less familiar with a historic involvement of children in genomic research and genomic screening, it might be helpful to level set here. So professional societies broadly recommend limiting pediatric prospective genetic screening or testing to honor the interests of the child and preserve their future autonomy. The exceptions that are granted are typically when doing some sort of predictive genetic testing might impact medical management of the child's condition during childhood. However, as clinical and direct-to-consumer genetic testing expands to pediatric populations, young people's perspectives on their opportunities to participate in genomic research or to learn genetic information about themselves that may not necessarily be relevant during childhood have increased. So we know that there are increasing opportunities to participate in genomic research, that the American College of Medical Genetics and Genomics has updated now 3 times their recommendations around returning secondary findings in clinical genomic testing. There are more opportunities for parents or guardians to submit their child's sample for direct-to-consumer testing, and there are opportunities and proof of concept studies that are assessing population genomic screening platforms as well. So there have been, in the period of time that I've been working in this space, increasing opportunities for young people to get genetic information about themselves that may or may not be actionable during childhood. So my own study is called Engaging Adolescents in Decisions about Return of Genomic Research Results. And the aims of our study are to explore adolescents' decision-making regarding learning personal genomic screening results. So individuals who enroll in this study don't necessarily undergo genomic screening, but they all make decisions about whether they would like to participate in personal genetic testing. Our goal is to assess how young people's age and various socio-demographic features factor into decisional preferences, and whether those conflict with shared decision-making goals, and how they perceive their results as well. We are interested in understanding how adolescent values resonate with professional society guidelines for predictive genomic testing that I just described. So are adolescents and their parents on the same page as the professional societies that made recommendations largely in the absence of empirical data, as many of the guidelines that were first developed in the 1990s were meant to try to be responsive to the availability of genetic testing that has become much more expansive today than when those guidelines were first developed. And certainly the professional societies have adapted and expanded their goals over time, including some that have argued that when involving young people in genetic testing, there should be engagement of those populations in the discussions about whether and when to undergo testing, though there hasn't been a lot of detail released as of yet as to how one would go about doing this. Our overarching goal is to contribute to best practices for facilitating informed decision-making in a manner that's consistent with adolescents' values and preferences and imposes minimal risk. So to give you a sense of the sort of workflow that occurs in this clinical trial that I co-lead with the genetic counselor from Cincinnati Children's Hospital, Melanie Myers, we engage recruitment of research participants who are between the ages of 13 and 21. They cannot be followed in a genetics clinic or have a molecular diagnosis, and they have to live within 100 miles of the study research center, which is an academic medical center in a tri-state area that has a variety of clinics that exist outside of that major academic medical center environment. Participants, once enrolled, are offered the opportunity to watch genetic education videos. I'm happy to share these slides if any of you would like to scan the QR code and see the slate of genetic education videos that we developed in the context of this study. And once they've reviewed these videos, individuals make choices about the kinds of genetic information that they would like to learn, be it for predictive conditions, treatable conditions, adult onset conditions, or carrier traits that were developed based on guidelines from the American College of Medical Genetics and the American College of Obstetrics and Gynecology around return of results. We then engage in a facilitated joint discussion between an adolescent and a member of our study team. And if the adolescent is under the age of 18, a parent or legal guardian is also involved. If the minor is under the age of 18, we only would return results about which they and their legal decision maker agree. Within the next 2 weeks, we assess decision stability, giving young people the opportunity to keep or change the choices that they made during a study visit. And for those who decide they would like to learn personal genetic information, a sample is collected and sent to a laboratory for genomic analysis, and we return results either by email or by video call, depending on the type of result. And I'll talk a little bit more about that later on. So there are a variety of ways in which we have used a decentralized clinical trial design in this particular study. The study was initially funded in 2019, but we had proposed to do an arm of the study that would be completely remote. We called it a telehealth model, but since then we've called it a virtual model. And we didn't have in mind that a global pandemic would push us towards increasing the utilization of this arm of the study. But I'm happy to tell you about our experiences because it's become much more than a pilot and has really become the dominant arm for the study. So we've used a variety of techniques that might be considered tools of decentralized clinical trials for recruitment. Specifically, the Engaging Adolescent study uses a variety of recruitment strategies to enroll a population representative sample of adolescents, with the goal of recruiting a population limited to no more than 50% of the population identifying as non-Hispanic white. Recruitment avenues include contacting patients from a pediatric biobank, leveraging social media communication, participating in community and school events, using community research advocates, posting flyers locally, mailing information letters to clinics, patients, and using follow-up automated text messaging to gauge patients' interest in participating in a clinical trial. And we've also used snowball sampling through a participant referral program. Our enrollment target is to enroll 440 participants, 240 who would be assenting adolescents between the ages of 13 and 17, along with a parent or legal guardian, as I mentioned, and then 200 consenting adolescents between the ages of 18 and 21, and they can decide whether or not they would like to enroll with a parent. As of yesterday, we've had more than half of the participants, about 200, and so we're still ongoing. We have less than 400 participants, but as of yesterday, more than 280 have been recruited through what we might call community arms of the study, or many of which are decentralized. And about 120 have been recruited from the institution, either from the biobank or from the letters and follow-up text messaging to the pediatrics clinic through their general and community pediatrics clinics affiliated with the academic medical center. What we have learned through these various recruitment strategies is that institutional policy can be a hindrance to decentralized clinical trial design and implementation, in that institutional policy restricted recruitment through social media platforms that are most frequently utilized by adolescents in the age ranges of 13 to 21, specifically Snapchat and TikTok, were recommended to us by a variety of community research advocates as avenues to reach this population, and yet we weren't able to utilize it due to restrictions on the uses of these platforms by the academic medical center. Not even by the IRB, but by the broader institutional policies around the uses of these platforms. We've also learned that young men and boys are less likely to volunteer to participate in genomic research studies such as this. And adolescents' availability is often limited to evenings and weekends. Adolescents who turn 18 during the study must be reconsented as adults, which adds an extra layer of complexity in a study trial design that's highly decentralized, and we don't have a lot of face-to-face interaction with the participants. We have also, as I mentioned before, proposed piloting a decentralized arm to the study using Zoom as the main platform for engaging with research participants. But when participants expressed interest in enrolling in the study, they are asked if they would like to participate in person or entirely via Zoom. It's totally up to individual participants' preference, and we're not randomizing. So what we've learned thus far is that participating in a decentralized format is more appealing to this particular age group. So as I mentioned, our goal is to recruit 440 participants. And so once participants agree to participate in the study, they select either in-person or virtual visit. And the in-person visits would happen at an academic medical center's research center. Participants consent or provide assent using an electronic form. And once enrolled, they complete a variety of baseline surveys via REDCap that can be completed either on their own mobile device or computer, or in using one of our study devices if they come in person. Oops, let's see here. Okay. So what we've learned thus far, thanks to work from one of our doctoral students on the study, Taylor Harrison, is that participant data from the ongoing trial that was retrieved in February of 2024 illustrated that 381 participants had completed a study visit, 42% of which, or 161, chose to participate in person, and 58%, or 220, chose to participate virtually. On this image, the blue dots are supposed to be cell phones. It might be a little hard to see. And the orange circles are in-person study visits. Participants who, and this is based on their street address that they give us as well in a tri-state area. Participants who chose to participate in person tended to be older, with a median age of 18, compared to those who chose to participate in a virtual study visit, where the median age was 16. Those who chose an in-person study visit reported higher confidence in filling out medical forms compared to those who chose a virtual study visit. And that's one of the questions that we ask people when they are first enrolling in the study. And we give them a Likert scale question to assess their confidence in participation in completion of medical forms. Younger participants, as well as participants reporting less confidence in filling out medical forms, tended to prefer virtual participation. And younger participants, we have to keep in mind, participate as a dyad with a parent or a guardian. So adolescent and parent schedule complexities and convenience may impact patients' preference for virtual participation. Virtual preference among individuals with less confidence filling out medical forms may suggest preference for a familiar, non-medical environment for engaging in research. These preliminary results suggest that decentralized participation options may help engage younger populations and those who self-identify as less confident in completing medical questionnaires and genomic research more broadly. So during the study visit, adolescents and young adults and a parent and guardian, if involved, are asked to complete an online decision tool that's been optimized for mobile devices. And so during a virtual study visit, they're separated into Zoom breakout rooms and asked to be in separate physical rooms from each other as well if they live together. In an in-person study visit, the young person and their parent are moved into separate physical rooms with a study facilitator. And after completing the tool independently, the participants and study facilitator are brought back together either into the same Zoom room or the same physical room to go through the decision tool for joint decision making. For minor results are only returned if the adolescent, their parent agree. And so what they're making decisions about are 75 different genes associated with 32 conditions that are derived from a mix of the American College of Medical Genetics and Genomics, secondary findings, recommendations, as well as the American College of Obstetricians and Gynecologists genes that they recommend for carrier testing. For individuals who decide that they are going to learn personal genetic information, they select whether or not they would like to provide a saliva sample or a blood sample. And in terms of the logistics of this sample collection, it is definitely more complicated when it comes to decentralized study visits. For instance, we can mail self-collection kits for saliva. They're using a package delivery service. And individuals can collect this on their own. They don't need to be part of, in the same room with a study team member. But we have found over time that there's more likelihood of sample contamination, sample failure, due to inadequate DNA being represented in saliva samples, and an increased need for recollection of saliva samples over time, which increase costs and delays progression of the clinical trial itself. Now, for blood samples, if a person participates in person at the academic medical center, getting a blood sample is that can be done right on the spot. But for individuals who select providing a blood sample who participate in a virtual study visit, they can go to any clinic associated with the academic medical center in the tri-state area. However, there needs to be a form on file so that the clinic knows that the individual is coming in for a blood draw for that particular study. And while that sounds quite simple, it ends up being a little complicated. And sometimes people go and give samples and the sample never gets to our study team. And other times the forms never make it and participants show up at the clinics and there's no record on file that that there is an order in the system for them to have a blood draw. So there's a little bit of clunkiness to it. And certainly there's a cost associated with having blood collection available at any phlebotomy lab associated with academic medical center. It's roughly about $11 per person though, which is actually a lot cheaper than do you use the saliva sample collection kits, which run $100 a pop. In terms of some of the ethical and logistical issues that we've encountered that we don't feel like have been very well articulated in the literature as of yet, we particularly like to highlight safety, privacy, distraction, engagement, and sort of the challenges of understanding participants' willingness to participate in a clinical trial and potential technical barriers to participation when researchers don't have control over the settings in which research is taking place. For instance, while we want participants to each be in their own space, their own private space for participating in a virtual study visit, depending on one's living arrangements, that's not always feasible. So there's potential bystander effect where we can't necessarily ensure that each participant is participating individually in their own space and without potential collaboration or participation of either non-study participants or other members of their family who are participating in the study with them. Sometimes this can be helpful in the sense that younger people can help their parents or legal guardians with technical challenges that emerge in the context of a study visit. But more often than not, we often find that participants who are doing virtual study visits are going about their daily, everyday activities in ways that might not necessarily be conducive to concentrated engagement in research. For instance, we noticed a trend of people calling into post-study visits while driving. And we ended up developing a policy to have all virtual visits rescheduled if a member of the parent or the adolescent was driving when they entered the study visit. But it's pretty common for us to find people going about other activities such as cooking or doing laundry or engaging in child or pet care during the course of a virtual study visit. Now, the level of tolerance that one might have for thin engagement in research, I think is something that is worth future attention in terms of the challenges and opportunities of implementing virtual study visits. One particular example I wanted to highlight was that using a platform like Zoom introduces some interesting interactions with study participants. So we had a 14-year-old male who participated in the study with his mother in a virtual study visit. The adolescent independently chose to receive results only for conditions that were treatable and preventable. He didn't want to learn adult onset results and he didn't want to learn carrier results. He made granular choices to exclude results for abnormal heartbeats. Independently, his mother chose to receive results for all possible conditions on the panel. In the joint decision session, the adolescent stated he didn't want to alter his choices, and the mother stated her desire to defer to the adolescent. The final choices were therefore to only receive results for conditions that were treatable and preventable. However, it's worth noting that during the independent decision making, the participants spent the first several minutes playing around with the Zoom filters, eventually replacing his head with an animated dog. During the joint decision making interview, the adolescent's mother commented that the filter was cute. Later, one of the study facilitators commented that she really wanted to learn how to make her head be an animal too. And the study facilitator felt that the filter made engaging with the adolescent more difficult because every time he would speak, it would bark and increase distractions for both the participant dyad and members of the study team. Throughout the study team, the facilitators noted that the adolescent seemed to be distracted by some sort of stimulus in the space where he was. So I will also just note that some of the things that we do when we return results. So for individuals who return results that are negative, meaning that there isn't a noticed gene change associated with the genetic condition, any of the genetic conditions that could be learned in our panel, those individuals receive results by email or by paper mail if there's a bounce back. And individuals who have results that are considered pathogenic or likely pathogenic or carrier results for an autosomal recessive condition are offered the opportunity to learn their results via a telehealth visit, also held via Zoom. As of yet, we have returned 297 results, 3% of which are associated with a pathogenic or likely pathogenic disease risk, and 13% of which are associated with being a carrier for an autosomal recessive condition. And what we've learned thus far is that just being asked to participate in a Zoom conversation about a result can produce anxiety for individuals because the result that itself is not disclosed during that initial introduction. However, interviews with adolescents who received carrier results that we've been conducting with a genetic counseling student, Haley Grimes, have illustrated that information recall of what the carrier results are that people can learn in this study are higher using this telehealth or Zoom return of results than a prior study in which we conducted return to carrier results via the electronic health record portal, MyChart. So we'll be assessing cascade testing, healthcare utilization, decision regret after return of results, and for individuals who receive positive results. We will be following up with them a year later to assess their experiences with this approach, particularly around the decentralized model. But we have noted the telehealth literature has suggested that that some of the distractions that we noted in the previous slide are not uncommon in telehealth delivery, and that it may be something that researchers and investigators who are interested in utilizing decentralized design ought to consider going forward, as it's likely to have a lot of the same effects. In terms of some of the positive lessons that we have learned through this and a previous study that adolescents want to be involved in decision-making about genomic screening, that they are capable of making independent decisions in private, and that they appreciate the opportunity for a facilitated discussion to confirm those choices over time. Very few participants revisit their choices at the 2-week mark, but that's something that we wanted to test in this clinical trial to see if it would be useful to build in that sort of bridge to a final decision. Prompting adolescents to share their opinions first places values on adolescent perspectives, often in settings where they aren't typically asked first, and their parents might often be asked to weigh in before their perspectives are solicited. And we have found that the joint decision-making process informs both parents and adolescents' decisions about which genetic information to learn about the adolescent. As of yet, no adolescents have voiced regrets about learning genomic information, and those that have received pathogenic or likely pathogenic results have prompted some parental testing and led to diagnoses and increased understanding of risk within the family. We know through this study that adolescents' choices may differ from parents, and we really do think it's important to emphasize strategies to afford adolescents an opportunity to have a voice as they're making this transition to adulthood, where they will be expected to make healthcare decisions for themselves. Ultimately, we have learned through conducting a clinical trial with a virtual arm that flexibility is key, both for study team members and for participants. We've had to have extraordinary flexibility in using a variety of different recruitment methods, contact methods, timing of study visits, and use of technology. Patience is really key here. And participants need to fit the study into the schedule of their own lives. And we, as researchers, must do our best to accommodate that, particularly when trying to enroll and retain and engage underrepresented research populations. I'll close with an example from a study visit that I conducted a few months ago with another 14-year-old male who participated with his mother. The adolescent study activities took longer than anticipated and occurred over the course of multiple study visits, when typically we would just have one. On the first scheduled study visit, the participants experienced technical issues trying to download Zoom. After navigating those technical issues, the adolescent still had not completed the assent form, so the study team decided to reschedule his study visit for the next day. At the next visit, the adolescent didn't turn on his camera, so the study staff checked to make sure that the adolescent and his mother were in separate rooms, and the mother had responsibilities other than the study visit, including caring for another child and a puppy. In total, the visit ended up taking 3 hours, twice the expected amount of time that we allot for these study visits. Despite the multiple lengthy study visits, the participants remained engaged throughout the process, and the study staff appreciated the participants' level of engagement and willingness to be adaptive in terms of scheduling and devoting their time to participating in the study. So I'd like to acknowledge my team at Mayo Clinic, at Cincinnati Children's Hospital, and our funder, the National Human Genome Research Institute. And I look forward to your questions. And I'm going to stop sharing my screen so I can see you all.
Thank you so much. So if you'd like to go ahead and either put your questions in the Q&A or the chat, or you're also more than welcome to raise your hand and we will call on you. We had one question that came up while you were presenting. Maya Hernert says, did the research project require parental consent?
Yes, so parents of minors who participate in the study do provide permission for their adolescent child to participate. So for anyone who is under the age of 18, the parent provides permission, written consent, and then the adolescent follows with providing written assent to participate in the study. They do go through the consent process together. So it's either in person at the academic medical center, on the phone, or in a virtual study visit format, like in a Zoom meeting. But yeah, so they go through it together, not separately, and then they sign separately.
Mm-hmm.
Thanks
Thank
for
you
that
so
question.
much. Yeah. Other questions? I see one hand up. Sorry, let me, let's see here. If you had your hand up, go ahead and unmute yourself if you'd like to.
Okay, I think I have a question.
Yes.
Can you hear me?
Hi, yes, go ahead.
Hi. Go ahead, Deborah.
Okay, so when you were talking about ethical consideration, you made mention of veracity, like checking the accuracy of the data results to be sure like the research is not kind of vague. So my first question is that how do we check this? Like, for example, if it's a medical data, do we have to call the doctor, or do we have to ask them to send their doctor's reports? How are we sure that the results they are giving us is actually accurate? Because since we are working with their results, definitely it's going to affect the reports. And then my second question is, you also talked about ethical oversight. So I wanted to know where to draw the line between ethical oversight and talking about veracity.
Mm-hmm. Yeah, thank you. Those are great questions. So what we find in a lot of decentralized trials is when we're talking about veracity, we want to ensure that the person who is inputting self-reported data is the research participant. So sometimes we need to go through the process of trying to verify the identity of the person who's participating in the study. And I can give you one example of a challenge with that. So, and this may or may not have to do with veracity of using a decentralized trial design, but it's a problem that can arise in that we had a research participant who sent in a sample for, it was a saliva sample. That saliva sample went to the laboratory that we work with, and the lab contacted us because the stated sex of the participant that we gave to correspond with the sample came back as the opposite sex as of the DNA sample that they sequenced. And so in that case, it may be a situation where there was a sample mix-up at the biobank before it went to the laboratory, but it could also be that somebody other than the research participant provided that saliva sample. And so what we did in that case was that we asked the participant to come in for a blood draw so that their identity could be verified by the phlebotomists before the blood draw was taken. So we didn't want to leave it up to chance that if we had them collect another remote study sample, that we would be able to verify that the identity of the person who provided a biological sample is the person who's enrolled in the study. So that's just one example. But more often than not, I don't think that we are trying to work in collaboration with clinicians to verify, the soundness of the data. It's more about trying to ensure that the people who are enrolling in our studies are the people that we think they are. So some studies require using video. Some require having someone show their form of identification, like at the outset of a study visit. There are just additional checks that need to be put in place that we often wouldn't do if a participant was coming into an academic medical center. Like I've never participated in a study, although I'm sure some do, where we ask for someone's ID when they come to the clinic. Like we generally, I think, presume that when they tell us who they are, that's who they are. But there are additional checks that I think are being put in place in this context. In terms of ethical oversight, in the literature, there has been some question about institutional review boards' facility with understanding the variety of ethical issues that might arise when you move research out of highly tightly controlled environments and into more messy environments in the real world. And so I think the question is not about inadequate oversight, but potentially about overly restrictive structures that make sense in an environment like a hospital where everything can be verified left and right. But what we find is that some of those procedures that you might put in place in a clinical research organization or an academic medical center aren't really practical if you're trying to take research out of the academic center. So this idea of trying to ensure privacy, ensuring that there are no bystanders involved in research, like we can't guarantee that. And so there can be some back and forth with institutional review boards about how much can we adapt our research design in order to ensure that we have that we're going to research participants instead of always making them come to us, particularly if there are travel and other burdens associated with trial participation that could be lowered by removing that barrier. Thanks for your question. Elizabeth, did you have a question or comment too?
Hi, thank you.
Yeah, I do have a question. So it's about I mean, I understand that adults and adolescents, they increasingly have access to genetic tests and direct-to-consumer genetic tests, all kinds of tests. And in the past, there was a huge discussion about, the right not to know, the right to an open future for children, for adolescents. What should adolescents know about, conditions that may show up in the future that may be relevant when they are adults. Or, I mean, there has been a huge. I think it's still ongoing. And on the other hand, I understand that everyone has more and more access to genetic tests. And against this, I was wondering. I mean, you said you had a set of tests that you chose for the study, isn't it? It's not direct to consumer genetic tests, and it's also not, genetic tests based on the family history, but it's a set of tests you chose. And you also talked about genomic screening. And I mean, that's my question. What sort of tests? What were they about? Is this thought to be a screening thing?
Yeah. No, that's a great question. And you're right. I mean, I think that the debate really has been heavily informed by the idea of retaining a right to an open future, which has limited the clinical application of genetic testing in minors to those who may benefit from some sort of intervention during childhood, and deferred other testing that may not impact people until adulthood, until the point where they themselves will be the legal decision makers in their care. However, we know that there are a lot more people who are getting genetic information. And so we were building off of existing guidelines from the American College of Medical Genetics and Genomics that recommends for anybody who gets genomic testing, there are certain types of results that should be returned, largely cancer-related and cardiovascular condition-related risk factors that have a genetic underpinning to them. And so that's the ACMG secondary findings list. It's been refined a variety of times. I don't exactly remember how many are on the list right now, but it's upwards of 60 conditions, or 60 genes associated with a variety of conditions. And then the American College of of Obstetricians and Gynecologists issued recommendations in 2017 around population carrier screening. So what we offer in the context of this study is a combination. We call it like a mix of the ACMG list, versions 2.3 or 2 and 3, and ACOG's list of carrier tests that they recommend. It results in 75 genes associated with 32 different conditions. And in the slides that I sent, there's a demo tool, and I can send the tool so you can see all of the conditions that people would learn about, and it lists whether they would learn carrier traits or their own personal risk. And so it is considered a form of prospective genomic screening because individuals are not considered to be at risk. And so it's emulating the idea of population level screening for all those things that are on the ACMG secondary findings list and ACOG's list of recommended carrier screening. We know that carrier screening largely doesn't take place before people determine that they are ready to build a family. And yet there are increasingly, very, very heavily populated screening tools that are used during pregnancy that can identify carrier risk. And so we're trying to anticipate in some ways the information that individuals could learn in the course of their own healthcare, but perhaps not until it's in a situation where they're already confronting a more challenging situation of trying to manage their own care or managing an existing pregnancy, for instance. So yes, it's considered genomic screening because there's no clinical indication. It's a panel that we developed in the based on existing professional guidelines. Is there anything more I can answer about that?
Thanks a lot. That's really interesting. Wow.
Yeah.
And
it's been fun and not scalable. We've learned.
Question. Normally, those adolescents, they wouldn't have access to this panel, isn't it? That's
correct.
It's like, I mean, yeah.
They would not, unless they were undergoing genomic testing for some other clinical indication, they wouldn't learn this. And so, what we consider the positive rate has been estimated in the literature that if you were to offer population genomic screening like this, it's been projected that there would be a 10% positive rate. That 10% of those screened would come back with either a pathogenic or likely pathogenic or carrier result, or sometimes more than one. But what we're finding in our study is that it's higher than 10%. And we don't have an exact reason for that, other than that we think that people who have a known family history of a condition that could be genetic are more likely to be interested in participating in genetic research. And so this isn't published yet, but our genetic counseling student did interviews with individuals who indicated in one of their baseline surveys that they thought they would have a positive result, but then it came back negative. And so she interviewed them to find out, well, why did you think you were going to have a positive carrier result, for instance? And they would say, oh, well, we have a family history of cancer, or we have a family history of diabetes. And those are things that are on the panel, but not, every form of cancer or every form of diabetes, but rather these are the ones that have like a higher genetic prevalence, like MODY, for instance, or the BRCA1 and 2, Lynch syndrome, things like that. So people think they are more likely to have a result than actually is the case, but still we are within this study population, it's elevated above what we would expect for our population. In part, we think because people are interested in learning more about themselves and their genetic risk factors. And we're finding that adolescent girls and young women are a lot more interested in this information than their male counterparts. So yeah, that's where we continue to recruit.
May I ask now? So it's a self-selected group. And is there data out in the literature about, the interest of people to basically know know about their genes, let's put it that way? And do you find a higher percentage of adolescents who are interested in getting the results?
Mm-hmm. Yeah, that's a great question. So my collaborator, who's a genetic counselor, says that the literature shows that women are more interested in learning genetic information than men typically. So our study population reflects that gender imbalance so far, though we're trying really hard to shift it the other direction. But there isn't a whole lot of research about adolescents. In fact, I think that we're only one of 2 research groups in the US that has been doing this kind of work with adolescents who don't have a chronic medical condition like cancer, for instance. And so it's just 2 research centers right now that are trying to understand more on a population level who would participate. And I wouldn't say that it's entirely a self-selected group. Like certainly the population that's accruing from the community or through social media is self-selecting. However, we do have these 2 study populations that where we're reaching out to existing patients in a community pediatrics clinic, and also people who participated in a biobank. So those people might be more likely to participate in research because they already agreed to participate in a pediatric biobank. But the patient population has been really interesting because we've been focused on recruiting from patients that are situated in areas that experience high deprivation. So they're highly urban populations and a very rural population in a medically underserved area. And so we are seeing that the populations are somewhat different in terms of less likelihood to have ever participated in research, less familiarity with genetics compared to those who self-select into the study otherwise. So we'll be writing up a methods paper about that approach to recruiting through like a general community pediatrics clinic in the future. It's been really fascinating and challenging in many ways to really put ourselves into this setting, but I would totally recommend it as an approach for trying to think differently about how we approach research and who we consider research populations.
Thanks a lot.
Thank you so much. Are there any other questions? Okay, I think we've come to the end of our time, but thank you so much. This was a really
Sure.
fascinating discussion. I know I'm taking away a lot of things for our own work and thinking about how you get diverse populations and make it more accessible to individuals to take part.
Great. Well, thank you. It's my pleasure. And thanks so much for the opportunity today.
All right, thank you so much for joining us. Okay, have a good day.